Hi, my name is Tony. I'm a radiation oncologist with Bay Health Cancer Center. Thank you for inviting me to participate in Untitled Breast Cancer Consortium's Breast Cancer Update 2022. I'd like to briefly review today what radiation therapy is and what the role of radiation therapy is in treating breast cancer. And then I'd like to discuss a few updates on what's going on in breast radiotherapy. Radiation therapy has been an effective tool for treating cancer for more than 100 years. Radiation therapy is used with various forms of radiation to safely and effectively treat cancer and other diseases. I think 95% of radiation therapy use is to treat cancer. However, we also use radiation therapy to treat benign tumors. About 2/3 of all cancer patients will receive radiation therapy as part of their cancer treatment. Now, how does radiation therapy work? Well, radiation therapy works by damaging the DNA within the cancer cells. And when it does that, it destroys their ability to reproduce and cause cancer cells to die. When the damaged cancer cells are destroyed by radiation, our body naturally eliminates them. Our normal cells in our body can be affected by radiation also, but they can repair themselves in a way cancer cells cannot. I think you've probably all been exposed to medical radiation in your lifetime. Most of us have had chest x-rays or CAT scan. Well, this is the same type of radiation we use for radiation treatment for breast cancer. The difference is that the type of radiation we use for treatment is much higher in energy than the typical radiation that's used for chest x-rays or CAT scans. So as you can see in the picture here, our radiation therapy passes through your breast, treating the entire breast and the cancer. What makes the cancer cells different? Well, radiation therapy cannot recognize the difference between the cancer cells and normal cells. But what makes the cancer cells different from normal cells is that the cancer cells have unnatural ability to reproduce themselves, and they keep dividing and growing out of control. But at the same time, these cells are very weak, and they're easily damaged by radiation, whereas the normal cells are a lot more resistant to radiation damages, and they can repair themselves within 6 to 8 hours. So we take advantage of this principle, and we're radiating daily for 6 to 6.5 weeks. And what happens at the end is all the cancer cells will be dead because they can't repair themselves, and the normal cells will be slightly injured, but they'll recover with time. This is what linear accelerator looks like. This is a typical machine that we use called TrueBeam. At the circular head is where the radiation beam comes out of, and this beam can rotate 360 degrees around this table. The table can also rotate around 360 degrees, and the tables also move in and out. By movements of the tables and the gantry of the head of the machine, we're able to treat all parts of the body. Now, prior to delivery of radiation, the radiation therapy is carefully planned. And this is an example of what radiation therapy planning looks like for breast cancer. I have to say breast cancer treatment is relatively a simple plan. However, this is an example where the green outlines the target, which is the breast tissue that we'd like to treat. The red outlines some of the heart structures that we want to avoid. And the yellow is outlining the normal lung. You can see that this is a two-field design where there's a beam coming from the top and the bottom, kind of treating the breast and avoiding the heart. But at the same time, there's a small portion of lung that's been receiving some radiation in the field of radiation. And the way we get around that is that from over 100 years of giving radiation therapy to patients, we've learned how much normal tissue can tolerate, how much radiation normal tissue can tolerate. And we can calculate the amount of radiation that's being exposed to the lung and find what a safe dose of exposure to the lung is, and make sure that we're delivering a full dose to the lung, yet we're keeping the normal tissue tolerance within safe levels. And this is what radiation doctors study during their training. Now, what are the side effects of radiation therapy for breast cancer? Well, the side effects of radiation therapy for breast cancer is very comparable to sun irritation. So, for example, let's say there's a 6-week course of radiation therapy. For the first couple of weeks, patient may not feel anything during the treatment. Starting 3rd and 4th week, the skin may develop slight redness and dryness in the field of radiation therapy. Maybe 5th and 6th week, you may develop some blistering of the skin at wet peels or the dry peel of the skin. And when you're done with the radiation therapy in 6 weeks, most patients will have tanning of the skin, just like a suntan. And we treat it just like a sunburn. So if the skin's red and dry, we'll ask you to use moisturizing cream. If the skin's inflamed and irritated, then we may prescribe steroid cream to just calm the area. If there's a blistering of the skin, or broken skin, then we may ask you to use antibiotic ointment to prevent infections. And at the end, when you have tanning of the skin, we'll ask you to use moisturizing cream over the next few weeks until all the tan peels and your normal color returns. And that, it's really not like a fire burn or electric burn. It's just like a sunburn, and we treat it just like a sunburn. As far as the long-term side effects, there could be slight contracture of the breast, not only from the radiation, but a lot from the surgery also, because when a surgeon operates, they're taking a big chunk of breast tissue out also. Initially, after the surgery, the area is filled with body fluids, and it looks pretty full. However, as time goes on, the body fluid gets resorbed, and the scars kind of start to pull in, and there's a slight contracture of the breast. And the radiation can also kind of make the skin a little more firm in the area, and the contracture becomes a lot more obvious. Despite the slight change in the skin texture and the contraction of the breast, 85% of the people are very happy with the way the breast looks, and certainly it looks a lot better than mastectomy. Now, why would someone receive radiation therapy for breast cancer? There's two main reasons that I want you to walk away understanding. Number one reason we use radiation therapy is to avoid mastectomy. So in early stage breast cancer, those are small breast cancer or non-invasive breast cancer, or that cancers that haven't traveled to the lymph node yet. In those situations, the treatment is generally mastectomy. You have to have the entire breast removed in order for cancer not to come back. But we learned over time that you could remove the lump and treat the remaining breast with radiation therapy, and that is comparable to having mastectomy. So that is why we use radiation. Radiation is purely for the purpose to avoid mastectomies in early stage breast cancer. So the reason I'm saying it this way is that if you don't mind mastectomy, then you don't have to have radiation in early stage breast cancers. Now but the role for radiation therapy is a little different in more advanced breast cancer. So the advanced breast cancer, meaning those breast cancers that are larger, or those breast cancers that have already traveled to the lymph node. In those situations, we use radiation after the surgery, regardless of what type of surgery you've had, whether it's lumpectomy or mastectomy. So it's no longer cosmetic, it's actually to improve local control and overall survival. So in summary, use of radiation therapy in early stage breast cancer is for cosmetic reasons only, to avoid mastectomies. Now, use of radiation therapy in more advanced breast cancer, in those breast cancers that are larger and those breast cancers that have already traveled to the lymph node, radiation therapy is used not for cosmetic reasons, but to improve local control and survival. So regardless of whether you have lumpectomy or whether you have mastectomy, you'll need radiation therapy in more advanced breast cancer. Now, what's happening in the field of radiation therapy? What's new in radiation therapy? There are three things that I'd like to discuss today. Number one is partial breast radiation therapy. I think you probably have heard of partial breast radiation therapy. Traditionally, we've treated the entire breast with radiation therapy, as I shown you earlier. However, we're finding now that in some low-grade small tumors, especially in elderly patients, we may be able to just treat a portion of the breast and still have pretty effective outcome. And there are many devices that we use for partial breast radiation therapy. The three most commonly used technology is number one, X-ray beam radiation therapy, which you've seen earlier, which is just a photon beam or beam of light that passes through the breast. Instead of treating the entire breast, we just treat a portion of the breast. The second technology that we use is called high-dose brachytherapy. This is where we actually use live radioactive source that's stored in a robotic machine, which travels out through wire catheters and travels into the surgical cavity via pre-implanted catheters like the Savvy catheter or Mammocyte catheter or contour balloon catheters. And then they treat the lumpectomy cavity and travels back out to the storage area by itself. And the third technology that we typically use is called intra-operation therapy, where radiation therapy is given during the course of where the radiation therapy is given during surgery. Right after our surgeon removes a lump, the machine's portable machine is rolled into the operating room, and single shot of radiation treatment is delivered right at the time of the surgery. And you can obviously add to that versus coming back for treatment. Everything's done at the time of the surgery. Now, I like to go into a little more details and show you pictures of what each partial breast treatment technology looks like. This is the initial one that I talked about. This is very similar to the whole breast radiation. On the left, you see a person receiving whole breast radiation therapy, where there's a beam of light treating the entire breast. On the right side is what we call a partial breast radiation, where we direct our beams from multiple fields into just one portion of the small portion of the breast. And this is called obviously partial breast radiation therapy. And this is commonly used. And treatment course for this can range from usually the treatment course for this would be about 3 to 4 weeks of radiation therapy. Now, this partial restoration therapy using high-dose radioactive sources, that's one that I explained to you, where there's a live radioactive source stored in a robotic machine here, and it travels through a guiding wire and goes into a catheter that's implanted in the patient's surgical cavity at the time of the surgery. So it travels, radioactive source travels through this line, sits at the center of the catheter, whether it's balloon catheter or static catheter, and irradiates the breast tissues and goes right back out. Typically, this treatment course is 1 week or 5 days, twice a day. So patient will be coming in the morning and afternoon for the treatment twice a day, and the total duration is usually 5 consecutive days. On the last day, we deflate the balloon and just pull the catheter out, and the skin heals on its own. You can obviously see the advantage of this is that the treatment course is much shorter. So patients patients want shorter treatment course, and this is a very popular treatment. Now, the third technology that I like to discuss with partial restoration therapy is intra-operation therapy, and this is what these machines look like. On the left side is a low-energy kV or photon-based machine, a kilovoltage machine, and what happens is that there's radiation that's generated from this machine. It travels through this rod into a spherical attachment here, which gets inserted into the surgical cavity right after lumpectomy, and the radiation is delivered right then. It's a single shot treatment during the time of the radiation. Now, this is a similar idea. This is a Mobitron machine, which shoots out, instead of the photon beams, different type of radiation called electron beams, and is guided through a lead tube into the surgical cavity, and it treats the surgical bed, and it's a single shot treatment. Now, the advantage of this treatment is a single shot and everything's done at the time of the surgery. The downside to this is that it's very difficult to deliver a homogeneous dose to the entire surgical cavity using this technology. So it's only reserved for very few situations where you have very tiny tumors with very low risk of recurrence, and also for those patients who are not able to come back for radiation therapy, outpatient radiation therapy. Now, second thing that's happening in our field of radiation therapy is there's been a significant change in the duration of radiation therapy course for breast cancer. Typically, patients were receiving 5 to 6.5 week course of radiation therapy, and that's been standard for many years, over the past 30 years. However, we're finding that in some patients, they may qualify for shorter 3 to 4 week course of radiation therapy. And of course, this is not for everyone, but this is limited by chest wall diameter and the breast size, and sometimes the volume of the area in the chest that we need to treat. Third thing that's happening, and it's the most exciting part, is the radiotherapy using genomic data. So gene sequencing studies like the Oncotype DX and MammoPrint have shown to be a good predictor for local recurrence, as well as distant metastasis in studies. And what these are is the gene profiling. So what they're doing is they're taking a sample of your actual tumor and running gene analysis to see what the correlation is between this type of gene and the risk of cancer traveling to other parts of the body or coming back in the breast. Now, the medical oncologists have been using this technology for many years to decide whether somebody needs chemotherapy or not. But this hasn't really caught on in radiation. But we're finding that now the Oncotype DX and the MammoPrint gene sequencing are actually useful in predicting local recurrence as well as distant metastasis, meaning cancer that comes back in other parts of the body. So using this data, now there are several studies going on to find out if someone has a low Oncotype DX or MammoPrint score, if they can be spared radiation treatment. And initial preliminary studies are showing some promise. So it may be that in the future, many patients with small, low-grade tumors may be undergoing Oncotype or MammoPrint gene sequencing to determine whether they need radiation therapy or not. There's another gene sequencing called Radiosensitivity Index, where this is actually a 10-gene radiosensitivity sequencing, where they take a sample of your tumor and run this 10-gene analysis on it to see how sensitive these tumors are to radiation. And what they're doing is, depending on the sensitivity of the gene profile, they're determining what the total radiation dose should be. So if you have a gene sequencing that's very sensitive to radiation, they feel that maybe you don't have to give as much radiation. And whereas if you have gene sequencing that's very radio resistant, they feel that you need to give more dose of radiation therapy to kill all the cancer cells. So in theory, these technologies will personalize radiation therapy such that when somebody has breast cancer, we'll take their sample of their tumor to decide whether somebody needs radiation therapy and how much radiation therapy they need. And this is exciting part of radiation therapy. Once again, this is not ready for prime time yet, but this is something that a lot of people are looking at right now, looking at a big study, and has an excellent potential for personalizing radiation therapy for individual patients. So in summary, I'd like to just recap the three updates in radiation therapy. Number one is partial breast radiation therapy rather than everyone receiving whole breast radiation therapy as we have done in past 20 to 30 years. Now a good number of patients are receiving partial breast radiation therapy using several technologies that I've mentioned earlier, including traditional external beam radiation therapy or high-dose rate brachytherapy or intra-operation therapy. Now, second update is the treatment duration. Instead of everyone receiving a standard 5 to 6.5 week course of radiation therapy, many patients are now qualifying for a shorter treatment course. Once again, this is limited by the volume of the area that we need to treat, the diameter of the chest wall, and the size of the breast, because in the larger breast and larger volume, the shorter course of radiation therapy will give a lot more side effect than the scarring versus the standard course of radiation therapy. So once again, this is something to discuss with your radiation doctor, and many patients may qualify for now shorter treatment course of radiation therapy. But lastly, the most exciting part is radiotherapy using genomic data. Now we're still working on ability to take each individual's breast cancer samples and run genomic analysis to determine whether a person needs radiation therapy and how much radiation therapy should be given to individual patient. In the future, I think this will play a much bigger role, as it's playing much larger role in chemotherapy, also in delivery of chemotherapy also. Well, thank you. Thank you once again for allowing me to participate in this update in breast cancer. I'd be happy to take any questions at this time. Thank you.